wonderful momentum for small and sick newborn care at present. And as we move fast in many countries, we can all learn from each other. We risk repeating or reinventing the wheel. And this is a very important focus within this toolkit of infection and infection prevention. So we're starting and we'll be led through this by the two co-leaders of this group. But before we jump into the webinar, we just want to flag that we will also be having sessions on each of these other components: infrastructure, what are we learning, human resources, family-centered care, so much going on in many different countries. Please, we welcome you to join. We welcome you to bring your ideas, share your tools on the toolkit, but also share your implementation learning. So I'm going to pass you over to open the webinar with Dr. Kondwani Kawaza, who is a fantastic clinician and neonatologist working in Malawi. And he's the co-lead of this group with Dr. James Cross. So over to the fantastic Kondwani Kawaza. And in the meantime, we will try to make sure that you can see the slides. So if you could let us know if you can see them now. Kondwani is going to take us through this agenda and the introduction.
Thank you, Prof. Joy. Welcome, colleagues. As Joy has mentioned, my name is Dr. Kondwani Kawaza from Malawi, working with the Kamuzu University of Health Sciences. So welcome to this first session of the Health System Building Blocks Seminar for Small and Sick Newborn Care, titled Infection Prevention and Control. Today, we'll be discussing the neonatal infection detection gap, especially looking to move from plenty of data that we have and plenty of evidence that is available to actually actionable solutions to close the gap. As you know, this is an interactive seminar, so welcome you to post any comments, questions, reflections, learnings, and also there's going to be a Q&A section. Please feel free. This is not strictly a webinar, but a chat and interactive session. Next slide, please. So, as you know, currently neonatal survival is a global priority. About 2.5 million babies dying globally, and 80% of them are from causes that are easily preventable and also treatable. Currently, there's a lot of energy towards ameliorating the problem of neonatal mortality. As you know, the SDGs are in place with targets to reduce neonatal mortality to less than 12 per 1,000 live births by 2030. This is SDG target number 3.2. Also, again, you know that the NAP target is 80% of our districts in LMICs to have facilities for providing level 2 newborn care by 2025. So what needs to be done? As you know, there's already published a WHO standards of care for small and sick newborns. This came out in 2020, where it details a set of standards for improving the quality of care for small and sick newborns in health facilities. The demand is huge. Approximately 30 million newborns would require admissions to facilities each year. And these babies are especially vulnerable to infections, especially hospital-associated and antimicrobial resistant infections due to their immature immune systems. And these babies are very brittle and more likely to die if infected. Can I have the next slide, please? Focusing on healthcare-associated infections and antimicrobial resistant infections, this is one of the biggest threats to neonatal survival. The incidence in LMICs is estimated to be 9 times higher than in high income settings. In South Asia, you would like to know that over 50,000 neonates in India and over 25,000 neonates in Pakistan die each year from infections that are resistant to standard antibiotics. In terms of quality statement number 1.12, this one speaks specifically to having standards for neonatal infection management in facilities. And the cornerstones are mainly three. One, to have in place preventive strategies. Number two, for early detection of infection. And number three, focusing on appropriate antibiotic prescribing and supportive care. Next slide, please. So that was just an overview. At this time, I'd like to invite Dr. James Cross and Dr. Sarah Collins from London School of Hygiene and Tropical Medicine to take us through the next slides. Thank you.
Thank you, Kondwani, for a brilliant introduction. I'm James Cross, a research fellow at NEST 360 based at LSHTM, and I have a clinical background in microbiology, and my current work focuses on the neonatal inpatient data set and also co-lead for the IPC HSBB group. So firstly, I just want to start by introducing how the IPC HSBB is structured in order to help combat a number of the issues raised in Kondwani's slides, and how our group work and learning have shaped over the past couple of years. So the IPC HSBB is separated into three components. The three themes can be seen here in a pathway of managing newborns with infection. So firstly, prevention and control of neonatal infections. This is focusing on aspects relating to halting transmission, protecting caregivers and health workers. Secondly, the next phase is infection detection. This theme currently focuses on the ascertainment of true cases in order to help guide treatment and care. And finally, we focus on the care of neonatal infections, and this theme provides useful guidelines and standards for the care of neonates, carefully advocated by recognized bodies. It also includes further information on halting outbreak propagation. And structuring this HSBB in this way has aligned it with one of our most recent outputs, and that's the production of the first scoping review to describe and synthesize published literature on the use of neonatal IPC bundles in regards to healthcare associated infections in newborn units in low and middle income countries. Next slide, please. And this Next 360 led scoping review consisted of 44 studies, of which all the elements of each bundle were classified. One of the key findings was that only 12 elements were related to infection detection. This evidence synthesis, combined with our team's experiences of working in newborn wards across low and middle income countries, really highlighted that neonatal infection detection as a component of clinical care is often being overlooked. And we are now on that journey together to improve this significant gap and build this culture of doing cultures. Today, we hope to take you through our initial findings and learnings, but crucially hear your thoughts and experiences, feedback on how we can start to correct this issue and improve inpatient newborn outcomes across the globe. Next slide, please. So first, even though many on this call will be experienced in the process of culture, we wanted to align by providing some background information in respect to this. So in terms of culture or blood or CSF is the gold standard diagnostic for neonatal sepsis. And this is considered the standard practice in resource-rich settings. However, many clinical teams know that culture can suffer from time delays, reliability issues, and contamination. However, it's important to note that culturing bacteria has existed for centuries and that clinical blood culture has been doable for over 50 years. So simple, proven mitigation strategies to improve this culture pathway do exist. In regard to point of care testing, a cheap and effective point of care test for neonatal infections is still some way off. And here are some of the common challenges seen at the bottom here. And this is a great area of innovation and potential. And we hope that as we talk about NEST, we'll provide evidence that this could be a great network for evaluating new point of care tests in the future. Ultimately, though, we believe that culture is the foundation on which innovation can be both supported and also compared. Next slide, please. So following this evidence synthesis of the detection gap, we began to pull apart the stages of the blood culture pathway. This simplistic process map documents the journey from blood draw to the use of laboratory results to inform clinical care. We hope to use this map to aid the evaluation of neonatal culture use and help to identify potential bottlenecks, whilst also using it to align and also aid our discussions today about your experiences of newborn culture in your setting. So firstly, we begin with the newborn entering the newborn unit, followed by a clinical assessment. And on the basis of being an unwell newborn with suspected infection, the clinical team decide to conduct a culture. Next. The specimen should be collected using a defined protocol, which provide details relating to materials, blood sample volume, culture bottles used and handling. And the newborn at this point may be administered empirical antibiotics according to local guidelines. Next, please. The specimens are then transported outside of the ward to the laboratory and regard this as the interface. And samples should be stored and carried with using specific conditions with time limits, formally received at a specimen reception in all hours at the laboratory. Next, please. Following arrival and check-in at the laboratory, trained laboratory staff are required to follow approved laboratory protocols. And apologies to any clinical microbiologists on the call today, because this is quite an oversimplified orange section that we're showing, but it's just to aid readability. However, we understand that these lab processes are complex and differ between facilities, but we're keen to try and support the development and use of simplified laboratory protocols and try that are appropriate for the laboratory environment and the skills of that team, and also the infrastructure and materials available to them. And when inside this section, we also see that sensitivity testing is available. And we are keen to support and enhance this use where possible. As you're aware, there are an increasing number of newborns that are dying of resistant infections, and many current treatments are becoming ineffective, as mentioned this morning, actually, in a recent press release from GARP. Next. Following ascertainment of a result, results are then required to be communicated back to appropriate clinical team and documented to aid data collection. This would also aid care quality and also better understand local etiologies and resistant profiles. Next. Clinical teams can then manage the care of a newborn by either stopping antibiotics in the case of a negative culture or administering a new antibiotic treatment. And this simplified process map captures the important overlapping components of each departmental work stream and the feedback loop within this pathway. We believe that this approach to the culture gap is critical to breaking down those traditional silos of thinking and also building stronger working relationships and processes. And we believe that these work streams overlay and rely on each other. For instance, taking samples from newborns is challenging, waiting for a result can be frustrating, and at the same time, conducting laboratory work on poor quality samples can be quite annoying. So health workers across departments need to be able to trust and rely on the quality of the work of their co-workers. And so to summarize this slide, we really believe that this interdepartmental quality improvement and communication is really critical to really implementing a change. Next slide. So now I'd just like to provide some details on NEST 360 before we start to review some of the data outputs relating to the use of blood culture in these facilities. So NEST 360 Newborn Essential Solutions and Technologies is a multi-partner alliance bringing together national governments in 4 African countries, Malawi, Kenya, Tanzania, and Nigeria, with engineers, clinicians, and health systems implementation experts. The NEST Alliance aims to halve deaths of inpatient newborns to support the SDG 3.2 and WHO UNICEF's QED initiative. And a health systems package, including a bundle of devices, is being implemented in 65 health facilities across 4 countries with a multi-pronged approach to improving the quality of care safely and sustainably, with data-informed decision-making at its heart. And facilities implementing NEST 360 have an annual newborn admission rate of over 90,000 newborns. And so now to take us through some of the initial quantitative analysis we've done on the detection gap across facilities implementing NEST 360, I pass over to Dr. Sarah Collins. Sarah.
Hello, everyone. My name is Sarah Collins, and I'm a medical doctor working in pediatrics connected to the NEST 360 group based at LSHTM. So noting that the infection detection is a gap in global neonatal care bundles, we then had a look at real world data from NEST 360. And we described the gap between antibiotic and microbiological culture use for over 47,000 admissions across 50 facilities implementing NEST 360 at both the country and the facility level. And we found a major gap between antibiotic and culture use, both blood and CSF culture, for inpatient newborn care at the country level. So if you join me in looking at figure 1, the dark blue bar indicates the percentage of newborns admitted who received antibiotics, which you can see is a stark contrast to the percentage who received a blood culture, which is the second bar, or a CSF culture, the third bar. If we look at the first set of bars, for example, which is data pooled across the 50 included sites, of the 47,068 newborn admissions, 78.3%, which is just under 34,000 babies, received an antibiotic during admission, but only 1,824 and 149 blood and CSF cultures were performed respectively. It must be noted that all these included facilities reported access to a lab. However, we also looked at the gap between antibiotic and culture use at the facility level, which is depicted in figure 2, and found variation between facilities with positive outliers in each country. In other words, facilities performing a high number of cultures for newborns with clinically defined infections. These are cultures conducted under routine care rather than as part of research. And why this finding is exciting and should encourage all of us is that it shows that cultures are doable in this context. In other words, a culture of doing cultures, as we keep saying, is possible. Next. And in just a bit, we will actually be hearing from Dr. Shayo from KCMC in Tanzania, which is the outperforming facility in that country, whose culture use rate was 70% for newborns with clinically defined infections. Next. So following this quantitative work, we wanted to get a clearer picture as to why these facility differences exist. Why do some facilities perform more cultures than others? So to answer this question, we drafted facilities into categories or tiers based on an analysis of lab capacity to actually conduct neonatal culture. This will allow the NEST 360 team to progress with a new approach to assisting in the quality improvement of infection detection in each facility. It provides a framework for us to be able to compare facility level culture use based on whether that facility actually has a lab or a microbiology department, for example. This enables focus on a more tailored facility-specific approach to improve and strengthen culture use, rather than a one-size-fits-all mentality. With our tiered approach, tier 1 facilities, those in green, are those with no lab services available. And as mentioned earlier, there are currently no facilities implementing NEST that lack a lab. Tier 2 facilities, in purple, are sites for potential infection detection and improvement, where the majority of NEST 360 implementing facilities lie. These facilities range from those that have a lab, but no capacity for micro workup, see tier 2.1, to facilities with a lab and micro capacity, but performing fewer than 5% of cultures on neonatal samples, see tier 2.2. Tier 2.3 facilities are those with lab and microservices, but are performing less than 50% of cultures. Tier 3 facilities, in blue, are those with greater laboratory capacity. In other words, teaching or referral hospitals with a laboratory, micro workup, and are culturing more than 50% of neonatal samples. In 3.1, and antibiotic sensitivity testing in tier 3.2. Next. It's critical to note that the ability of a facility to move from tier 1 to 2.2 or from tier 3.1 to 3.2 is particularly challenging, as either the installation of a lab or highly specialized lab technicians are required. Hence, our aim is focused more on assisting tier 2 facilities moving up through the tiers toward tier 3 by understanding what significant bottlenecks to culture might exist at each tier. The implications of further planned qualitative research, which will be discussed in the next slide, will provide actionable solutions that are tier specific in order to improve culture use at these facilities. Next. Additional researchers plan to contextualize and further interpret variation in antibiotic and culture use at facilities of similar context and capacity. This is key to understand what might be driving the culture gap. Feedback from quality improvement initiatives in some NEST 360 implementing facilities is that drivers are more nuanced than only lack of blood culture bottles. Our planned approach is to systematically select 10 facilities, the highest performing facility in each country, and the facility from each of the lower tiers with the highest number of admissions. Semi-structured interviews and observational checklists will be used for data collection at these sites. These tools will be structured around the health system building blocks, as you can see depicted on the right-hand side of the slide, to ensure a broad understanding of potential bottlenecks to culture use within each health system building block. Importantly, interviews will be held with both ward and lab staff to gain a more holistic idea of the culture process. Observation will be especially critical for the assessment of activities that actually relate to the ward lab interface. And that's that part where the specimen goes from ward to lab and results are communicated from lab to ward and actually seeing what happens in that space. The outputs of the qualitative component of this research will be twofold: to identify significant bottlenecks by health system building block and to create general and tier specific actionable solutions that will inform targeted action plans to close the gap. Visits to these facilities are planned in July and early August. This research is very much built on the belief that we learn from each other and therefore move faster together in sharing ideas about barriers, but really focusing on the factors at facilities that enable them to provide high quality small and sick newborn care. I'll now hand back to James, who will show us how data can be used for action.
Thanks, Sarah. Great description of our ongoing work. So, but some might ask basically at the moment, what are facility teams and members of the NEST 360 group doing today to improve newborn outcomes related to infection? So in late 2020 and early 2021, NEST 360 reviewed and enhanced all of our data tools to focus more on newborn infections. Importantly, these data are now being used for action as part of a QI process across all NEST facilities. This is with the aim of driving actionable change at the facility and at national level. In this example, you can see here, we follow the use of data for action at a NEST 360 facility that we'll call Facility X. In Q3 of 2021, Facility X received a QI dashboard, as you can see here under point 1, visualizing key indicators within the facility. During in-depth discussions as part of the QI visit, the clinical team were able to be alerted to the situation where there was a low diagnosis of sepsis, a non-existent culture confirmed diagnosis of infection, and a high antibiotic use on the ward. As previously mentioned, we've described this as the infection detection gap, as you can see in point 2. During the QI visit, NEST 360 QI facilitators teamed up with clinical staff to identify the highest priority problem via decision matrix, identifying root causes, actions, responsible persons, indicators, etc. So now I'm going to pass over to Dr. Nahya Salim and Aisa Shayo to take us through their clinical experiences of caring for newborns with infections and how they and their colleagues are trying to turn the tide on high use of antibiotics and the low blood culture use in their setting.
Thank you, James. Thank you, everyone. Can you hear me well? So I take it as a yes. Yes, my name is Nahya Salim, and I'll be taking you through the experience in Tanzania, the barriers actually of the cultures of doing cultures, the experience of Tanzania. And then my colleague, Dr. Aisa, will take us through the facilitators. As you noted in the previous presentation, KCMC is one of the facility in Tanzania with high performance in terms of blood culture detection, detection of infection. So if you look at the what just James presented on the data for action. So we had a workshop in Tanzania, including all the 7 facilities implementing NEST. And we discussed in depth in terms of detection prevention, infection detection, using actual data from each facility participating within NEST. We came up with a lot of solutions specific to specific sites. But overall, if you look at the performance of all the capacity of all the 7 facilities, most of the facilities in Tanzania actually lies in the tier 2 potential detection improvement sites. Because in only 2 facilities, we noted that they don't have the capacity of doing cultures. That means they don't have a backtech machine for this purpose. And where the backtech machines or the capacity is available, in most of the facilities, you see the reasons are lack of consumables. So backtech vials or bottles are not available, identification kits are not available, or antibiotic discs are not available or at a minimal availability. And this actually affects the effectiveness of detection, because you see some of the antibiotic testing which are done are not comprehensive, and they're not covering the antibiotics we usually use. So this becomes a frustrating factor to the clinicians when they are receiving the results. But again, the perception that culture are expensive to be done. So in our settings in Tanzania, all newborns are treated for free of charge, and most of these are lacking health insurance coverage. So in most of the facilities, they see like this cannot be done because it's too expensive and the newborns are not paying. So this is just, again, the perception which we can change. And then, as everyone have mentioned, is communication barrier between the lab and the clinical team. So the lab clinical interface really needs to be improved, because this is a key barrier. And usually as clinicians, if we don't communicate with the lab, we are frustrated, because on the other side, if you look at the blood culture results, usually it takes 3 to 5 days to receive your initial or final results. So for us clinicians, sometimes we see like this is too long, and the child may be, responding to treatment. So why waiting for culture? Why doing culture? So all these, facilitate these culture of doing culture. Most of the babies usually are admitted fever-free, but then they usually develop fever in the course of admission. And then you see, now clinicians start struggling. I did not collect the blood culture initially, so why should I collect here? Do I have to collect? Do I have not, and then you are in a puzzle and you cannot entangle it. So we need to stick to the standards as presented by James. So a sample collection technique, also James has highlighted that. Usually we have very high rates of contamination, and this could be a discouraging factor to the clinical team. But again, in some of the, if we learn from other facilities, usually they have a trained group who are usually, accredited for blood culture collection to just minimize the contamination rates. Another real factor which usually frustrates clinicians or nurses, even the parents, is the amount of blood to be collected. Usually we need 2 to 3 mils of blood, and this could be needed in 2 bottles if you want to collect aerobic and anaerobic bottle, in the 2 media. So this sometimes, as a clinical team, you feel like this is too much to collect from these tiny babies. But it is somehow, in a long run, it is more cost effective to collect these cultures, because you will spend little in terms of treatment and hospital stay, but also saving lives of these newborns. and make prevention and infection control possible. So at this juncture, I would like to welcome Aisa, Dr. Aisa Shayo, my colleague from Kilimanjaro Christian Medical Center, to learn how they have managed to tackle this culture of doing culture and making it possible on the other side. Dr. Aisa, welcome.
Thank you very much, Dr. Nahya. I hope everybody can hear me. I'm so happy to be among those who did well. And it's not just as easy, but as the other said, it's a culture of doing culture. I'm so grateful with our previous senior pediatrician. I think those are the one who make this thing happen, and it's going on to the department up to now. For us, how we practice normally, once you suspect a child with a infection, either on admission or later after admission, before starting any child in antibiotic, I mean the neonate, even the older children, you need to do a blood culture. That's the rule of thumb for the department. And after that, we take the culture in a special bottle for pediatric. The fear of how much blood, I think for us is gone, because we want to make that child alive, so the culture will assist us on management. As you know, nowadays we have much resistance to antibiotic. So after taking a culture is when the child being stepped on the antibiotic. And when we take that sample to the lab, we have also a good cooperation with the lab, because at the reception where they receive sample, they look at it and see if the sample is enough, you use the appropriate bottle. So likewise, apply to the culture bottle. They assess it, if they see it's enough and what we did is okay. Actually, the sterility and whatever, we have been, teaching each other in the world, because when we have the results which show contamination, the person who took it need to be sit together with other persons so to be taught how to do the proper collection. So after all those assessments, the sample is there to the lab, and we have still a good communication. Once they have a culture positive, sometimes could be early, within 24 hours, they call us to the department and tell the patient, so the culture grow this, while they are continuing to do the sensitivity. And normally the results, as Nahya say, is normally out within, 3 to 5 days. Normally we find we have already the culture results. So what I can say, like to our hospital, I know in Tanzania most under 5 they have been treated free, but us it's like it's a government private hospital, so they normally pay for it. And in case if the mother or the parent don't have a money current, there's an exemption from the social welfare, where they do the exemption, but later they follow it for them to pay. So the payment does not stop us not to take the culture. So there's another way to make sure that the culture has been stepped paid, because at the lab they need all the sample which is taken them, there should be cleared on the payment. I think that's enough. Nahya, do I have to say anything more, dear?
I think you mentioned it very nicely, Aisa, Dr. Aisa, because we learn from you now, because I think from what I presented as barriers, you actually explained it as facilitators. So this actually highlights that this is possible. So the culture of doing culture is actually in our heads, and it's possible to be done. At this juncture, I would like to take back to our chairperson, Professor Joylon. The chair is yours. We can move to the group discussion. I cannot see any questions yet.
Asante. So first of all, I would really like to thank Dr. Aisa and also Dr. Nahya for just fantastic sharing, and double thank you because it's a holiday in Tanzania where I also am. We really welcome your questions from the chat, and I think there was so much richness in Kondwani's introduction on the issue of hospital-acquired infections. James bringing his strength as a microbiologist, looking at how we can use data to look at that gap, but also, what next? And then Sarah, understanding the whys. So I can see we have some wonderful people all now promoted as panelists, and I know that many of you are working in this area, maybe on issues of how do we improve blood culture. I can see Valentina who did a review in this area. I can see a number of other people. So don't be shy. Please feel free to post your questions or ideas or suggestions. Here's some thoughts that we had about the discussion. So I think, we saw data from the ward side, and we heard, beautifully from Kilimanjaro Christian Medical Center. We heard about the lab. What are some of the things there? And then I think Nahya especially talked about the interface. Many of these facilities that we're working in NEST, they have the lab, and we have clinicians who I'm sure would like the blood culture, but maybe the interface is not working. So maybe I'm not seeing any questions. Yeah, Robert is saying, we need to make it a norm. So I think that sometimes maybe people, are not expecting to do cultures. So that norm that Dr. Aisa has particularly underlined. Kondwani, I know you have done some work on this in Malawi. I don't know if you want to comment also, how do we do this in a normal hospital setting, not a research lab, so that we can really track particularly antimicrobial resistance. Kondwani, any things you would like to add?
Yes, Joy, essentially, I think most issues have been tackled by our colleagues from Tanzania. In respect to the work that you mentioned or referred to, we had done some hospital facility looking at the state of care, and some interesting results that are coming out. Of course, in the secondary level hospitals, there's not much being done in terms of diagnostics for infection. Specifically for culture, there's nothing. But interestingly, when we looked closely in our assessment, we find that the facilities are available. So all the hospitals, as Joy mentioned, have the lab facilities available. And in some places, the hospitals have facilities for doing culture, but it's just not happening. So some of the barriers really are the interface, some of the barriers are in terms of leadership, in terms of knowing what is available and what is not available, and where to find help, and also some issues relating to human capacity. So it's interesting that it's not an infrastructural problem for the most part, but it's the system issues. People really
thank you, Kondwani. Yes, sorry, didn't mean to interrupt. I think that's such an important point, and I think Sarah is an optimist. She said, we have barriers, but we also have this opportunity. We have the things in our hands. So Liz, Professor Molyneux is asking us a question around that, which is that, for quality improvement, both in taking the sample, but also in, understanding contaminants. So I don't know, Dr. Aisa, can you comment on this for us? What have you done in KCMC to improve the quality of taking the cultures and reduce contaminants? Nahya highlighted it as a gap. Is there something you can give us as a tip?
For us in Tanzania, thank you. Actually, there are so many training on how to take the sample, and the lab people also assist us at the QI team. So you find it like an habit because have one and on training, and also they do reassess. Once they see there are much of them having the contamination, especially if we have a new doctor, that something take place. That's all what we are doing. But again, I think the work culture of doing blood culture also have a place on it. Thank you.
That's excellent. And then there's a specific question also about the cost. So, you know, I think in KCMC, one of the reasons that you highlighted is maybe because you can charge for the services. But as we know, you know, we do have true negative and also false negative blood cultures. Is this a barrier with families?
It's for me again. Hello?
So the question was, if you have a negative blood culture, are families not happy to pay for a blood culture that is negative?
No, I mean, when we look, we ask them to pay, it's like it's part of management. We want to know what is going on to the baby so that we can treat her and the baby can be cured. So most of the women we find that they do agree so that their baby can be cured. So when it's negative and we tell them it's negative, they don't bother about the money which they pay, but they are happy their child is okay. That's, I think, it's the only thing help us. There's no one complaining that it's negative. Why did they pay it? No. They found already been treated on antibiotics.
Sorry, Padline, I didn't mean to interrupt. I can see questions are coming thick and fast. So if we don't get to your question now, we will try to do it afterwards on Twitter, just to encourage everybody again to join this group, which is a very interactive group, which James and Kondwani facilitate. So you're all welcome to join this. And I see interesting questions about CSF as well. And there was a question about point of care diagnostics that we missed earlier. James, can I just ask if you would like to answer on that one?
Yeah, thanks, Joy. I think, you know, there are a number of biomarkers that have emerged over recent years that are really offering some promise, and really is the cutting edge of innovation to get these out onto the market and being used regularly within care. For instance, like procalcitonin, IL-6, CRP, NGAL, for instance. But there are still a lot of questions in regards to these point of care tests and what role they really play in the clinical care of newborns. And so on reflection of a number of recent diagnostic reviews looking at these, I think we've still some way to go, but NEST is involved in trying to think about target product profiles for a point of care diagnostic and how that can be supported. And we're very interested in potentially using NEST as a platform in the future, maybe to think about these kind of tests and how that they could be used in the future. But it's a very good point. But at the moment, ultimately, as I say, culture is the sort of bedrock foundation, which I think these can be built on. So yeah.
Thank you, James. Yes, and I think, you know, looking at host response, but also looking at organism. So there is a group B strep one that's really close to coming to market, but obviously only one organism. So I see also a really important question about surveillance, environmental surveillance, and particularly because that is more costly and also sometimes hard to interpret if done routinely. I don't know, James, do you want to take that one as well, or is there someone else who would like to answer on that?
Sorry, Joy, which maybe someone else can take that.
A question on routine environmental surveillance in neonatal units.
I know that there are some individuals on the call that have a great experience of that. Personally, I'm not somebody who's done great things in environmental swabbing, but I understand that it's something that's definitely picking up in pace in terms of literature in the recent years. I know that Dr. Uduaka-Koma has been doing some work, and I believe Dr. Helen Brotherton also has also been involved in that work in the Gambia. I don't know if they are also on the call at the moment, but maybe.
So my suggestion is that we do a session on that and also on antibiotic stewardship in this infection group. Maybe you can find, you know, maybe Helen or Uduak and maybe Alex or others would like to talk about that stewardship. I think it would be lovely, you know, we have got a limited time here, but we really welcome ideas for other sessions. Join the group. We also really welcome ideas for other things to include on the toolkit. So if you have a learning, you know, on routine surveillance, or you have a learning on antimicrobial stewardship, on microbial stewardship, then we would really welcome that. Nahya, do you want to make these comments about outborn versus inborn antibiotic use?
Yes, Prof. So in most of tertiary facilities, usually, there's this factor of history of antibiotic. So most of the outbounds received have already been exposed to a certain level of antibiotics. Most of the time is first line, even second line now currently. So I think a repeat culture or doing culture in that patient is actually very critical, because you may have antibiotic, but it may not be the right one. It may not be, treating the infection intended. It may not be given in the right dose or in the right frequency. So repeat or doing a culture, the first culture, second culture, actually give us a chance of identifying the causative organism. Back to you, Prof.
Yeah, thank you. And I think the questions are coming thick and fast. There's some comments here from Sian about environmental swabbing. And I think this is what I have also heard from low and middle income countries, that the cost effectiveness for environmental testing after an outbreak is more, it has a better cost effectiveness ratio at present than doing routine swabbing all the time. So I would be interested to hear if other people, Helen or others, may want to post in the chat about that. I see that Sarah has her hand up. Sarah, would you like to also comment on this?
That is probably another Sarah Collins. I think there are a couple of them on the call.
Sarah has conveniently cloned herself, so whichever Sarah, feel free to unmute yourself and contribute.
I think my only, oh yeah, go for it, the other Sarah. Anyone there?
Somebody with their hand up.
Yeah, Prof. Joy, may I recognize the presence of Dr. Robin from Germany? Actually, this is, we have a new grant supported by GIZ. Maybe Dr. Robin, can you say something on this? But this will be about surveillance and also taking samples for microbiome study. Dr. Robin, welcome.
Yeah, hello everybody. Yeah, it's a fund by the German GIZ. We will look and do some surveillance about drug resistance and also try to investigate the microbiome of neonates in Dar es Salaam. And I'm really looking forward to this project, which has just started, so I can't really give any experiences on that, but I'm really looking forward to be a part of it. Thank you.
Thank you, Robin. And that's just wonderful. I mean, so important. I think, the burden of neonatal deaths and also infections is in low and middle income countries. And we need more of this research and also linking to action across all of Africa, Asia, and around the world. We are running out of time. I'm so sorry we missed some questions. I see a brilliant one by Aluvala here. I don't know if anybody wants to quickly take this before we close. So I think this is also on the environmental swabbing. I don't know. So the question is, instead of environmental swabbing, and maybe where that's not available, should we consider genital tract swabbing in the delivery suite? And I think maybe particularly thinking of group B strep. Is there anybody on the panel who would like to take that question? We can also share, if helpful, we did some work with WHO last year on group B strep estimates. There are about 20 million pregnant women worldwide who carry group B strep. And most of those are in countries where we're not routinely swabbing, and certainly contributes to excess deaths. There are also vaccines in process. And ironically, the vaccine may end up being more cost effective than swabbing everybody and treating everybody. So I think on this note, I would like to say Asante Sana to everybody, and I pass back to Kondwani to close us and just to welcome everybody again. Please do contribute your ideas and tools on the toolkit. Please do join other seminars and please join this specific group, which is really wanting to develop a learning community. So hand back to Kondwani to close us.
Thank you so much, Prof. Joy. I'd like to thank my fellow panelists. Again, I'd like to extend my thanks to NEST 360 and UNICEF for supporting the work. And thank you all colleagues for attending. As mentioned, this is the first of many webinars that are going to be organized by NEST 360, focusing on the HSSBs. So you're welcome to attend subsequent sessions and to contribute. Once again, thank you so much, everyone. I think now we can consider the session finished. Thank you.
Thank you.
Thank you very much.
Thank you.
Especially to those on holidays today.
Thank you.
Thank you,
Bye.
Professor.